Okay, in this video we're doing heart failure. I'm going to use the same slides that you guys have in PowerPoint. Just because I'm going to try to expedite this quite a bit, I'm going to use the same slides so you'll see which ones I'm skipping over, just for the sake of expediency. So we mentioned this before, heart failure is any condition where the heart fails to provide enough blood flow, failing to provide enough pressure to perfuse the brain and a contracted muscle, or more importantly, and this is the important part with heart failure, fails to adequately provide perfusion pressure to the kidney. So if it doesn't have enough pressure to drive renal perfusion, then you get fluid accumulation, and that's one of the main problems with heart failure. I didn't normally include this with some of the other ones, but aging is commonly associated with heart failure. As you'll see, as the heart ages, it develops plastic changes in the heart that diminish its capability to generate pressure. Both males and females, the prevalence in older women is because many of the men with heart failure have already died. So heart failure can be acquired by a variety of different things. There's going to be two slides on this. The two most important I want you to remember is number 1 and 2. So anything that causes a loss of fidelity of left ventricular muscle capacity. So loss of muscle, and the most common thing there is usually some subclinical heart attacks. And this is a diminished capability of the blood flow to the heart to provide the musculature with enough nutrients to pump adequately. So loss of muscle, and obviously that's part of the aging process as well, and that happens in the left ventricle. More commonly is elevated workload of the heart that's associated with maintaining pressure and hypertension. So if you have a lot of back pressure, increased cardiac output, vascular hypertrophy that causes high blood pressure, that increases the workload of the heart that leads to heart failure. Infectious disease, myopathic diseases, hypertrophic cardiomyopathy causes heart failure. But those number 1 and number 2 are the most common progressive causes of heart failure. You can also get more transient causes of heart failure, where heart failure, symptoms of heart failure will come and go. If someone dramatic inappropriate reduction in therapy, like if someone was on a low sodium diet and they switched to a normal sodium diet, that can put them into heart failure. If they've been on a fluid restriction, that's common after cardiovascular procedures, cardiac bypass and such. In the heart, they're on fluid restriction, then they go off that fluid restriction, and then develop the symptoms of heart failure after that. And then a variety of different medications, beta blockers, alpha blockers, calcium channel blockers, ACE inhibitors. If you're taking that medication to control blood pressure and then you go off those meds, that can cause heart failure as well, the symptoms of heart failure. Not the same as the number 1 and number 2 that we did before, but then associated with therapy. Usually that entails going back on a low sodium diet or fluid restriction or medications to control the heart failure. Any arrhythmia that decreases cardiac output could cause heart failure. And again, it's not a failure of the ventricle to generate pressure, it's a failure of either the electrical activity or timing of the heart to provide adequate cardiac output. And then, like a lot of the other things, there's a variety of infectious diseases that can cause heart failure as well. Again, like the last slide, these two can cause more transient. I'm going back to the last slide very quickly. Chronic heart failure, CHF, number 1 and number 2, and then more transient heart failure are the arrhythmias, dysrhythmias, and then changes in therapeutic interventions. So the symptoms of heart failure, all of these have the same pathology, fluid accumulation. So when fluid accumulates, and again, just follow the pathology of this. If the heart can't generate enough pressure to adequately perfuse the kidney doesn't rid the body of extra fluid, fluid accumulates, and all of these symptoms are a result of fluid accumulation. So respiratory distress, notice right there, that is the cardinal manifestation, accumulation of fluid around the thoracic cavity. And again, fluid accumulation from the inability of the kidneys to filter that extra fluid builds up in the lungs. It can cause breathlessness. And if we go down to here, paroxysmal nocturnal dyspnea, these are the same types of pathology. This is just one where a lot of times you'll have somebody and they just have a difficult time catching their breath even without exertion. That would be respiratory distress. And then at night, the nocturnal Paroxysmal dyspnea is where someone has fluid accumulation, they're laying flat, it accumulates enough to where it produces this really stark, almost panic feeling where they wake up and they're having a difficult time catching their breath. Both of these things are alleviated by being in an upright posture so the fluid doesn't accumulate in the thoracic cavity. Exertional dyspnea, obviously anytime you exert yourself you get breathless. Dyspnea is breathlessness. But then here you're getting exertional dyspnea out of proportion to the physical activity. So literally standing causes breathlessness or inability to catch your breath. So I've also tried to demonstrate this one before, but the idea that you have respiratory distress and then you have a non-productive cough. A lot of times it's a dry cough. It's exacerbated if you lay down for a long period of time. Sometimes it's associated with breathlessness. Sometimes during the end of an exhalation, there'll be a cough at the end of that, or just a kind of a short, non-productive cough. And non-productive is the idea that stuff's not coming up that would produce that coughing kinds of things. Look over some of these physical manifestations. All of these, again, are associated with fluid accumulation, demonstration by the Valsalva maneuver. This is an important graph to illustrate heart failure. And rewind this if you need to go over it a few times. You guys are used to seeing atrial pressure and cardiac output when you're talking about Starling forces. If you increase preload on the heart, if you increase the skeletal muscle pump that increases venous return, you expect an increase in cardiac output. So in a normal heart, this curve is representing what happens in a normal heart. Or you have an increase in preload or atrial pressure that results in increased cardiac output. In a failing heart, in heart failure, the heart fails to respond normally. So even though you increase preload, you don't see the same increase in cardiac output. Part of that fluid accumulation actually helps to restore some of that cardiac function. As you accumulate fluid, that increases preload, and you can see even though that curve is flattened, it still does help to increase cardiac output. But then what you're seeing here is the main adaptations of your body. That fluid retention helps to increase preload, and then a sympathetic reflex, the sympathetic nervous system, tries to kick in to increase cardiac function so that you can match the ability of your heart with what is needed. So if you move outward on this curve, in a normal heart, you see a big increase in cardiac output with an increase in atrial pressure. Failing heart flattens that out. Fluid retention helps partially compensate for that. The sympathetic reflex, although it's partially effective, you can see this curve flattens quite a bit. If you let these go unchecked, the heart continues to fail because it becomes dilated. I'm going to just show you the dilation part. This is just showing, a lot of times we'll illustrate the left ventricle kind of as a cup. There you see the lumen, or the inside diameter that fills with fluid, the muscle on the outside. One of the things that happens with increased workload of the heart is the muscle thickens. And this is referred to as concentric hypertrophy, where the muscle thickens inward so that you get more ventricular muscle, but then the problem is the size of the left ventricle, the size of the stroke volume goes down. One of the things that can happen if you have chronic hypertension is the heart becomes dilated. And this is a dilated heart is where the increased back pressure from fluid accumulation continues to dilate the heart until it compromises its ability to pump. And you guys know that part of that dilation is less than optimal dilation of the skeletal muscle fibers, so that diminishes its capability to contract. I'm going to skip some of these heart failure kinds of things and skip to the treatment of heart failure. This is the outline treatment of heart failure. I'm going to highlight two main ideas for a failing heart. The first one is administration of what's referred to as a positive inotropic. You guys remember inotropic is something that describes how forcefully the heart contracts. So medications that act as positive inotropics are things that help the heart beat more forcefully. The idea with positive inotropic is that you're going to help restore some of that cardiac function, and that's going to get the kidney to be able to function more readily. The most common positive inotropic is the drug digitalis or digoxin. It's derived from the foxglove plant. It's been known for many years to increase the pumping action of the heart. If you do that alone, oftentimes you can exacerbate the heart failure. So what you do as well is you try to diminish fluid volume. So you give a positive inotropin and something that would act as a diuretic. And what we're going to try to illustrate on graphs like this, you can follow this through with something like an ACE inhibitor. But here what you're looking at is what happens if you give an inotropic and a diuretic. So if I go back to that treatment of the failing heart, the two main medications are something like digitalis and then a diuretic, positive inotropic like digitalis, and a diuretic. And the most common diuretic, I think, is Lasix. And in Lasix, so you want to administer a positive inotropic and a diuretic together. And what this is illustrating is, again, that Starling law, left ventricular filling pressure, that same as the preload from the atria and its influence on stroke volume. You're seeing a graph here illustrating a failing heart and a graph with a normal heart. And then when you take that failing heart, if you give a positive inotropic, that will cause stroke volume to go up dramatically because the heart beats more forcefully. That can lead to cardiac hypertrophy and a dilated heart. And then if you give just a diuretic, although you're alleviating that increased fluid accumulation and some of the respiratory problems, that, if you go back to that earlier slide, you see that fluid accumulation actually helps with some of the preload. So what they're showing on here is if you give that inotropic and that diuretic, a lot of times you can get increased heart function. And that's some of the pharmacological interventions are like a balancing act, trying to give an adequate amount of digoxin, an adequate amount of a diuretic like Lasix, so that you can get increased cardiac function and at least to trip the kidneys into doing a little bit more of what you want. All right, so just to summarize, heart failure can be the result of inability of the left ventricle to pump, whether that is due to something chronic like heart disease or the secondary effects of hypertension. And then the main treatment for that, the main symptoms, fluid accumulation. Although I did mention it earlier, edema, especially in the feet, is common when somebody's in upright posture. And then when that edema gets up into the lung area and causes respiratory distress, dyspnea and such. And then the treatment, Lasix and digoxin, a diuretic and a positive inotropic to help restore cardiac function. All right, good, let's go to the next one.